Just give a second.
Can you hear me?
Hey, it's been so long since I've seen you.
At least 24 hours.
So far away. It just feels like many years ago. Okay, I have my recording on the computer. We are ready. Hi guys, how you doing? Here we are for another live. So should we introduce Jerome first? Jerome Benoit. So he is American Boarded Radiation Therapy specialist. He works at the moment in France, but he's been working, obviously did his residency in the States, then worked in London for a little bit, and he's been the head of the service in his radiation oncology department for a while in France. And what is also, we're going to talk a little bit, is also how he is helping a lot of people to set up new teams of radiation oncology, which I think that a lot of people probably is going to be interested.
Mm-hmm. Okay.
So first thing, tell us, when you went back to Europe after your residency, how many other radiation therapy specialists were there in Europe?
So at the time we were about 5, so not so many. 5 mainly American boarded. We did a training in the US, but there are still about 25 centers doing radiation therapy in Europe. So a lot of these centers were doing radiation without the help of American boarded specialists, and there's no European diploma. There was no until now. So there's really a mixed practice in Europe at the moment with centers with specialists, like trained specialists, and centers who have been doing radiation for a long time and they've got their own experience and their protocols. So the way radiation is being practiced in Europe is quite mixed depending on the places, whereas it's more homogeneous in the States, where everybody has the same background. So
for everyone to understand a little bit, what's the difference? So what is different between you and an oncologist? Why there is radiation therapy college, which is completely different from an oncology? Mm-hmm. So just like kind of people a little bit understand what would be the difference if they're going to be speaking with you or they're going to be speaking with someone that does oncology, because you mainly treat oncology patients, right? Not only, but I guess that mainly. So what would be the main difference so then people understand a little bit why your specialty and your residency was different from an oncologist?
Mm-hmm. Well, I hope I can call myself an oncologist.
Okay.
So oncology is being done by many type of people, mainly medical oncologists, and by culture and the way it's done, it is true that medical oncologists tend to see cases first, do the investigation, the diagnostics, and so on. But in practice, depending on the disease, I would tend to see more solid tumors. And then some tumors are not eligible for surgery. Mm-hmm. But generally, the caseload I share, I tend to share it more with surgery in a way than with medical oncology. And medical oncology will do the treatments involving chemotherapy. Mm-hmm. So it would be hematopoietic tumors or high-grade tumors which necessitate chemotherapy. And then for any solid tumor, either after surgery or without surgery, then radiation therapy is a good modality of treatment. It's a local treatment. So most of what we do is a local treatment for local disease. And that's the main difference compared to medical oncologists who tend to see a disease that's more likely to spread to different places.
But also your job as a radiation therapy specialist is to do the planning and which someone that does medical oncology wouldn't have that training on how to use the machine and how to really select what is going to be the protocol and how do you want to treat that solid tumor.
Exactly. Yeah, so that's really the big difference in terms of training, and that's why we are from a separate college. Our college is linked to radiology because initially and culturally, The physics that we use for treatment are the same. We're using X-rays basically most of the time. So X-rays are the same as X-rays used for diagnostic. And the technology to target a tumor obviously is different than a CT scan. And so a lot, beside what we know about tumor biology and the type of tumor we see, a lot of our job is to so from the images, we do a lot of the work is behind the scene, doing some 3D MRT plans. And that's really, you can take hours sometimes. You know, you can spend hours to do a plan for one patient. I don't know if you're interested to know about you know, what is done, but basically so there's actually, 2 big steps.
Yeah.
Yeah. Can you hear me well?
There is one question. So, yeah, it's cutting a little bit. It's cutting a little bit, but hopefully it's going to be okay. The image looks a little bit, you look a little bit pixel. Okay. Or whether you have put a...
no, there's no filter.
filter. So there is actually a question, because you know, guys, that we are here for you to ask questions. I just keep asking Jerome questions until you ask questions, and we will hopefully explain a little bit how radiation works, and probably a lot of people, you're going to be concerned about side effects and things like that. So we have already one question that was asking, for the same type of tumor, if you have different dogs, how does radiation therapy change? So I guess that would you have a different type of protocol, even if it's the same tumor but a different type of dog? And would you see probably a different response, depends on a different dog, or will be more the different tumor?
So yeah, it's on a case-by-case basis, it's always very difficult to know what will be the response. And so there's different factors to take into account when we see a case. So from the tumor type, we know what type of radiation is needed and what protocol we want to use ideally. But at the end, it's the owner's decision if they want to go for the best possible protocol, or sometimes we go for alternative options. So 2 dogs with the same tumor might have different responses, because each tumor, even though it might be the same type, might not respond exactly the same way to the same protocol. But that's the same for, you know, in medicine for many diseases, and in oncology, same with chemotherapy. The big difference compared to chemo is at least we know exactly what dose we're giving to the tumor. If you give chemotherapy to a dog, you don't know exactly how much chemo goes to the tumor you're targeting. But with radiation, at least what we can guarantee is the very precise dose to the tumor we're treating. But then a lot of the discussion in consultation is usually around different aspects of the tumor type, and that gives some idea of what dose we need to use and what we should not use if it's not effective. And then a lot is about logistics. Would the owner consider the dog to be boarding during treatment? If they come from far away, some people accept for the dog to stay in hospital, and some people don't. They want to come for every visit, and sometimes it will affect the protocol. Also, in terms of side effects, some clients are just ready for everything, and they want to do the best, and they accept side effects for their patient, for their dog and cats. And some clients are just very against side effects. They don't want anything to compromise quality of life. And so obviously, 2 dogs, same tumor, or 10 dogs, same tumors, we might end up with 10 different protocols. And I think maybe more in private practice, I think we are probably listening a bit more to what are the objectives from the owners. So we have our standard protocols, but we try to adapt our protocols quite a lot to the client, because at the end, if they don't understand, if they're not ready for side effects, for the cost of the treatment, I don't think it's good service to give them. So maybe in some universities, it's a bit less flexible because of and the academic setting and the research. A lot of protocols are quite standardized, and it's quite difficult to go around them. In private practice, we play a little bit more around protocols.
So tell us a little bit. Let's say that I think that there's two questions that I think that could be probably interesting for people listening that maybe they don't use radiation therapy that much. So I think that probably you have in general people that get very scared with one, a side effect, and second, which I have been already have some situations here where some centers have refused giving radiation therapy to a patient that didn't have a diagnosed cancer, which in neurology, we know that if we do radiation therapies because we cannot remove it. Otherwise, we will just go and get it. So what will be the kind of the most common, less common, or more scary side effects? And what do you think about doing radiation without knowing what are you treating? What will be kind of benefits or not benefits? So then how available will be this technique for people, for neurology patients?
So are we only talking about neurology cases or generally? Because
yeah, I guess that depends how long is the generally, but yeah, mainly on.
If I do a quick general, the main acute side effects we see in radiation therapy are reactions of epithelial tissues, so skin and mucous membranes. So for them, if we're treating the face, like an old tumor, nasal tumor, anything along the skin, scars, somewhere in the abdomen where the intestines might be exposed, you will have quite significant side effects because of the acute reaction of this type of tissue. But for neuro cases, there's not much skin or mucous membrane within the brain. So actually they tend to tolerate the treatment very well, and there's very little side effects that we see for brain or spinal cases. There's some criteria that might affect the type of side effects, and we can almost call complications, because we can accept side effects to the skin, and this we can consider it's normal. But when it comes to brain irradiation, obviously we don't want any side effects. Yeah. And the main risk is probably some edema around the tumor we're treating. And because of the swelling, there's a few cases that could deteriorate during treatment. But with a good fractionated protocol, the risk is very small. It's very rare to see a dog doing worse because of radiation. It's maybe less than 5% of the cases. Now, if the dog is not medically stable at the beginning of radiation, if the tumor is very large, if there's a very large normal brain volume exposed because of the large tumor, obviously there's more risk for these cases, but they are more at risk anyway from the beginning because of the stage of the lesion. So to me, it's never, and it takes time for radiation to work. It's never an emergency treatment. And when it comes to neurology cases, the priority is the medical management. If the dog is not stable,
reduce that edema, reduce the edema around the tumor, so you have time for the radiation to kick in.
There's no point starting too soon. Otherwise, after 1, 2, 3 fractions, you'll have some problem during anesthesia, or the recovery will not be good, or the dog will have more seizures, or start to have some intracranial pressure issues. And then you have to stop the radiation protocol, and that's worse than starting later. So it's much more important to have a good medical treatment, make sure the dog is stabilized. Often I wait 10 days, 2 weeks before starting treatment after the first consultation, unless they are already fine and already on steroids.
Yeah, they've been stable.
Yeah.
So what I have had sometimes, which I know that even if it's like a little bit the radiation therapy in the brain, sometimes we have also dogs that they have a little bit, as you said, because of the epithelium into the GI system, sometimes they can get a little bit of diarrhea or some kind of signs, GI signs, even if the radiation is in the head. At least our team were saying that it was related to, could be related to. And then,
it's not a direct effect of the radiation to the gut, because it's very targeted.
Because it's target.
There's no radiation going outside what you're treating. So if the tumor is this big, that's where the radiation is going.
Okay.
Now, some dogs, it's true, if they stay in hospital because of this daily anesthetics or every other day, depending on protocol, they get a bit stressed. And I think a lot of this diarrhea is stress related or anesthesia related. Yeah.
Okay, so it's not going to be the field. And then sometimes they change in hair, which we don't care. Yeah.
First, we don't care. It's very slow because the brain target, the target volume is deep. The dose to the skin is not very high. So we don't see burns like we would see for another type of treatment. If it's more superficial, we tend not to see any burns. The only thing we might see is for a case with pituitary macroadenoma. For a small dog, maybe more, the ear canals go deep in towards the brain and the bullae. And so sometimes, depending on the beam arrangement, they might get a little bit of otitis.
Okay.
And for a giantess, if it's a very sort of ventral tumor at the base of the brains, I would say it's mainly small breeds. And because they're on steroids anyway during the whole course of radiation, it's still very rare that it really affects the patient. They keep eating, usually they're fine.
Yeah, exactly. I think that is important that we all really learn that as you said, that it's a very, very targeted treatment. And if you're using for the spine or for the brain, you're not going to have all the other symptoms that you could have if you were irradiating the tongue or the GI or something like that. And then the long-term side effects, they're not so common either when we're treating brain or spine. What would be kind of the long-term side effects?
It's mainly brain necrosis. So it sounds terrible, and it is terrible, but it's very rare. And that's really the key point. Most of these dogs are quite old when they get treatment. And when we talk about late side effects with radiation, usually it takes years before it happens. So the actual risk for a patient to develop complications like that is very small. But I would say if you have a youngish case, let's say an adult dog with a macroadenoma or meningioma, for which the prognosis can be actually quite good. And if the dog lives long enough, so 3, 4, 5 years, then yes, potentially later on, there might be signs that we might consider as potential complications. It's always difficult. So diagnosis is complicated. It's very rare we get a biopsy. So a lot of what we treat, that was one of your questions earlier, a lot of what we treat, we don't know what we treat. And even more with neurology cases. But
that is okay. And that is
why, it is okay.
As a neurologist, we're going to be using radiation therapy when we cannot remove that solitary mass that we see, right?
Yeah, exactly. And there's very few centers that would offer just a stereotactic biopsies without surgery. Most places that I see, it's either it's a surgical case and we might get a diagnosis after removal, or it's not surgical. I don't know many places that just do diagnostic biopsies for the sake of getting a diagnosis.
Yeah.
I would just be careful sometimes when cases look odd. There's no other way to say it. So basically, if you get a referral for a typical meningioma, it looks like a meningioma, it's the right age for meningioma, then I don't care if we don't have a biopsy.
Yeah.
What we will not know exactly is the grade of the meningioma. And there's very low grade ones, and there's a few which are a bit more aggressive. So potentially. Yeah. But there are other factors like the edema around the tumor that can help to think if it's an aggressive tumor or not so aggressive and so on. But sometimes we see,
exactly.
I get cases referred which are some weird cases. So young dog, the lesion on the scan or MRI scan is not that visible. There's no mass effect. And there's a few cases where I do not do radiation. If the dog is clinically completely fine, had maybe one fit and nothing else, I always worry that sometimes some of them might have some, I don't know, some vascular disease or something that's not cancer or not tumor. So there's a few cases where I say, okay, your dog is completely fine. I have a big doubt on the fact that there is a tumor in that brain. So let's just wait 1 month, maybe repeat an MRI or a month or 6 weeks, and then we decide later. But it's a very expensive treatment. There's risk for side effects, and obviously you don't want to treat a brain if there's no tumor to treat. But of course, we don't need a diagnosis all the time, because even in other locations, there are cases, the bigger it is and the more palliative we go for treatment, the less sometimes we need the diagnosis.
Because also the question is that what it is as a tumor is going to change the prognosis, but will your protocol change dramatically, knowing if you're treating histiocytic sarcoma versus a meningioma? Or it's just the prognosis?
Probably they would, prognosis, and probably there would be a change between the two. The main ones we would see, there's, let's say, 3 or 2 main categories. The benign ones, so meningiomas, macroadenomas, choroid plexus tumors.
Yeah.
Probably they don't need as much radiation. We don't need to push to the maximum dose. So if it looks benign, there's no edema, it's small, the dog is okay. That's a case where I don't necessarily push to the maximum treatment. Now for gliomas, I would tend potentially to increase slightly the dose, but it's based on nothing. In our literature, there's nothing to tell us what's the good dose.
Yeah.
But from the human experience, I think it's worth, if we have a suspicion of a small glioma, to try to push the dose a bit more. And a lot of the gliomas we see are probably low grade. They don't take contrast very well. There's no edema around. The dogs are usually okay. Maybe they have fits, and this can live for years with radiation. There's an old idea that gliomas are very bad, meningiomas are okay, but a lot of the literature we have is not very recent. And I think with the modern techniques that we have, the modern protocols that we use, a lot of what we see is really different from what we can read from the old literature.
I have had dogs with a suspected glioma that was 8 months with not even steroids, 8 months with just anti-epileptic treatment, absolutely nothing, no radiation, nothing. So agree that there is a lot of different. Let me just go and ask some questions that they've been going through. So there is one question about what will be, this is a very specific question, so it's very good. What will be your protocol for a stage 4 nasal tumor, and what will be the results?
So there's some, I don't know, residents, oncologists, specialists, or radiologists here. That's good.
The name is Tachi Clemente. I don't know what would be. So you know.
All right. The thing is, the staging system for nasal tumor is terrible. So from as soon as you have a small lysis of the cribriform plate, even without invasion, it's called stage 4. And so if you have a small nasal tumor, just slightly lytic to the cribriform plate, but very small, very localized to the back of the nose, I would go for a definitive treatment, no doubt. Even if there's a slight mass effect on the brain, if the volume of the tumor is relatively small, I would do, if the owner wants, a definitive treatment. What we call definitive is a curative intent. So a lot of fractions, high dose therapy. Now, if it's a bad stage 4, which is before being a stage 4, a stage 1, 2, 3, going into the orbit, under the skin, in the pharynx, and massively in the brain, obviously there's no way we do this. And it would be just a few fractions or some cycles of radiation spread apart by 2 or 3 weeks to avoid side effects, because the prognosis is very, very poor. So it's really dependent on the case, the volume of the tumor. Because side effects, the bigger the field around the head, the more side effects. All the skin, conjunctiva will react, the mucous membranes in the mouth. So the bigger the field, the more side effects we might see. So it's not fair for bad stage 4.
Yeah, because basically kind of protocols that in general are more or less available will be, some people will do like radiation every day for 1 week, or will be 3 to 4 weeks, or you will do different days. So there is a huge variety of amount of dose that you do in a single treatment, how many days, and also how you play around with maybe 1 week you will give some more, and then you see how it's responding. The dog is not doing that well, and then you reduce. So there is a lot of variety, right?
Yes, there's a lot of variety. And the smaller the fractions, the smaller the dose per fraction, the higher the total dose we can give. So it's always a compromise. And that's because biologically, the tissue will not tolerate a lot of big doses. Whereas for the same total dose, if you fractionate, if you divide in smaller fractions, the tolerance of the tissue will be much better. And that's extremely true for the brain tissue. So a lot of people think, including neurologists in some places, they think radiation fry the brain, or it's dangerous, can damage the brain. Yes, everything can, radiation can damage, but can appropriate for the brain tissue. And so for us, it would the big range will be a minimum of maybe 3-4 fractions, big doses, once a week. That's a typical palliative protocol. And the maximum would be 20 fractions every day for 4 weeks. But the dose difference is almost doubled from 4 to 20 fractions. The actual dose to the tumor is almost doubled.
So basically, let me just put it this simple. The problem also will be obviously side effects, but if you're doing more sessions with a lower dose, is going to cost more money, and you're going to have more anesthesia. But ideally, biologically, will be a little bit more interesting to be able to do more sessions with a lower dose for longer, or is also the amount of, just kind of the people understand, why we will use one protocol, or why we will push someone to do one protocol, or try to, spend more money to do more sessions. Oh, got stuck.
So if
you're frozen. Jerome.
Young.
Wait, we cannot hear you very well. Now, yes. You were freezing a little bit. Oh, I think that your Wi-Fi maybe is okay. Let's see. It's thinking.
I can hear you very well, and so I don't know. Can you hear me?
Yeah, now I can hear you.
Okay.
Yeah, now
so basically, the more hope you have for a patient, the more you should try to optimize your protocol. So if it's not too old, if the tumor is early stage and the dog is doing well, let's just do the best in a way. If the owner can afford it, it's always better. Potentially the dog can live for years. So it's better for the tumor.
For you then? And is there like a general, what will be better, to less and more, or that will depend on the tumor?
Yeah, well, if it's benign, we don't have to go to as many fractions, but there's still the same idea of trying to fractionate enough so we don't have complications. So maybe for benign brain tumor, I'm very happy with 15 sessions, for example. I think that's completely appropriate, and these dogs do very well. And the total dose is not the maximal dose we can give, but I think it's okay. If it's more malignant or like a glioma, then trying to push from 15 to 20 might bring some benefits, even though we don't know exactly. Now, there's another concept of radiation, which is called stereotactic radiation therapy, and that's mainly in the US at the moment. It involves a very specific type of equipment. The principle is to only give radiation to the tumor and pretty much no radiation to the surrounding tissue. And in that case, you can give a very high sort of curative dose, ablative dose in only 3 treatments, 1, 2, up to 5. It can be done over only 1 week. And it works very well. The problem is you are not able to treat any margins. Because you literally would fry and kill every normal tissue around the tumor you're treating. So the risk of side effects, it's considered to be higher in a way that if there's any edema around the tumor, it's such an acute, such a strong treatment, some dogs might deteriorate a bit more acutely. But in terms of logistics, it gives only a 1-week treatment in a few fractions. Can you hear me enough? Should I move to another place?
Yes, it was cut. Yeah, it was cutting a little bit. So that we could hear that you were saying that you, with the stereotactic, you're going to do like a shorter treatment, which would be the interesting thing. So there is another question, but let me just ask you a little bit about the concept of like how radiation therapy works, because we know that radiation therapy is not an immediate treatment. You don't put the dog on the linear accelerator and the next day the tumor has shrunk. I think that that's a concept that, because we know that radiation therapy shrinks the tumor, but how does that work? Is it about, well, how does that work?
It's magic. It's just magic.
And why does it take a little bit of time? And why do you have this kind of vague of effects? And then like around a certain time, depending on the tumor, how fast the tumor grows, you have a better effect or a slower effect?
So the simple explanation is that we break DNA in pieces, but we don't necessarily kill the cell immediately. So if we do some DNA damage, the cell can survive for a few cycles, and then eventually, by accumulating chromosomal damage because of the division, eventually it will die, but it takes time. And so if it's a high-grade tumor, which is quickly dividing, you will see the effect quicker because the tumor is trying to divide all the time. So if there's any damage to the DNA, it will be clinical very quickly. If it's a low-grade tumor or benign tumor, the effects of radiation can last for months or years. If you follow a meningioma after radiation, every 6 months you do a scan. Every 6 months, the tumor will be a few millimeters smaller, usually until a point where it just stays stable, and we don't know if it's alive or just sort of scar, sleeping tumor. So what's more important is not how good is the remission initially. That's not the only thing, because some tumors respond very quickly. It can disappear completely on the recheck scan after 2-3 months, but then it comes back 3 months later. So the more aggressive tumor, they can shrink very quickly, but they can also come back quicker. So if the dog is stable, it's much better to have a slow regression of the tumor, but that lasts forever if we can, for the life of the animal.
Yeah, because radiation therapy is attacking what we said, the fast growing cells, but you need to wait until that cell dies to really see that kind of reduce of the mass effect. And that is why it's taking a little bit of time. And that's why what you were saying, that it is important that we have start radiation therapy in a dog that is stable. So the same, if we are doing brain surgery, we're not going to start radiation therapy the day after surgery. We're going to probably wait 3-4 weeks, even up to a month after we do the brain surgery, that all the tissue is well, all the edema has gone down, and then we can start radiation. And as you said, this is a marathon. The radiation therapy is more like a marathon, and you need to have a patient that is going to be able to go through it.
Yeah. No, it's perfectly correct. In other indications, we would usually wait only 2 weeks after surgery. If you remove a sarcoma on the leg, we don't need to wait 4 weeks. And probably the sooner the better, even more for high-grade tumors. So you don't wait for the tumor to come back. But a lot of these brain tumors tend to be of a lower grade type, at least the one you probably operate. And the priority is really to have a patient that's completely stable before we start treatment. There's no point to rush into treatment. But once we start, we don't want to finish or to have interruption. To
stop in the middle.
It's important to, exactly, we want to just go and finish it as planned if possible. Now with brains, it's so important to keep monitoring your patient. And some clients, sometimes they're not so sure about the protocol they want to use. They feel that sometimes every day is a bit too much. They're concerned about the anesthetics. So it's typically a very good case where you can say, let's start with every day because your dog is perfectly fine. And I think it will be okay. But in case there's a difficult recovery or we feel anesthesia is not very stable, we can always adapt the protocol and go to every other day. That might be better for your dog. So it's always an option, and that's from the beginning, and then it's rare that we change. But for brain, sometimes we change slightly during treatment.
So another question regarding a specific kind of type of tumor, which is not a neurology question, but for chemodectomas, which are difficult to do a pericardectomy and remove them, would you be using radiation therapy on these cases? Could we use radiation therapy?
It's described, so technically we can. So usually with radiation, we can do everything in a way. As long as we can target the lesion, the volume, it's something we can treat. The question is, what is the actual benefit of it? The way it's been described in the literature is probably benefits cases who have heart insufficiency or pericardial effusion. So some secondary complication because of the tumor. But otherwise, I don't know if it's indicated for every case, because we know that a lot of dogs can live forever with a tumor.
Yeah.
And there's risk, during the treatment, there's risks for the heart, the lungs around. So it's not so easy to do, and you need a quite precise type of technique of radiation to do it well. So I would say it really depends on what case and what's the objective. But probably not for every single case of chemodectoma, I don't think so.
Okay, and then there is 2 questions regarding lymphoma. So one, lymphoma and radiation therapy. So is it possible, what type of lymphoma would you treat with radiation? And then the question within lymphoma, what about if you have a low-grade lymphoma and you don't have radiation therapy? And then also there was the same kind of question regarding what about only using steroids, which the problem is that lymphoma is like...
So lymphoma...
Like one specialty, no? It could be it's the diplomate of lymphoma college.
Yeah.
Yeah.
There's so many types of lymphoma, so it depends what we're talking about here. If I talk about the good indications with radiation and lymphoma, are the localized lymphoma. So nasal lymphoma in cats, we can cure with radiation. It doesn't spread very quickly. And lymphoma is so sensitive to radiation, it just goes away. In a few days, it's gone completely. Because lymphoma,
And
that's the one type of tumor that reacts quickly to radiation. It does apoptosis, just commits suicide every time it feels it's being irradiated. So nasal lymphoma, great indication. I use it for GI lymphoma in cats when they're in remission after chemotherapy or during the chemotherapy course, because they are high grade. For the high grade lymphoma, they tend to resist chemotherapy, and the median survival is not very good with chemotherapy alone. Mm-hmm. So that's a protocol I really like using. It's a very low dose. The total dose to the whole abdomen is a very low dose, but because lymphoma is so sensitive, I believe it brings a benefit for these cases.
Yeah.
Low-grade lymphoma, yes, if it's as a rescue, if it's failed chemotherapy and you feel the disease is progressing, why not?
But it wouldn't be your first approach.
No. I like to be, well, except for nasal lymphoma in cats, for the rest, I like to be a technician. So it's always a discussion with the medical oncologist, because it's usually part of a chemotherapy plan. And radiation alone is not enough. It will not replace chemotherapy. So in dogs, multicentric lymphoma, I'm not so sure it brings much benefit. These are old papers. I've done it a lot in Carolina. I don't think it brings much at all. Now, if we go from the lymphoma talk to the neurology, lymphoma in the brain is quite rare.
Yeah.
But GME, these are indications which are non-cancer, as far as we know, for which radiation brings an amazing response, amazing control. So if you have GME cases with a solitary tumor lesion or even multiple.
Yeah. The problem that we have with the GME, you see, I think that the GME are like I'm sure that a lot of diseases, we are going through phases of presentation. Mm-hmm. And the description of the GME, you have the multifocal, the solitary, the optic. It's been a while since I have seen a GME that is a solitary mass, and usually is multifocal, diffuse, and also kind of affecting the brainstem. So how comfortable will you be? Because, cerebellum, I would be thinking it's a little bit sensitive or not?
No, because the dose you give is small. So
it's small.
Like for lymphoma. So here we are treating some sort of inflammatory lesion. Yeah. Compared to 50 gray that we would give or try to give for glioma. For GME, what's been described is to give around 15, 20, 25 gray only.
Okay.
Few fractions. So that's where you get side effects. And at that level of dose, you can treat the entire brain. You can treat the brainstem. So it can be multifocal and you treat the entire brain. And it has a very powerful effect on the lesions. So I'm not saying it's a first line treatment modality.
No, but when we have a lot of side effects with medication and limitation with people giving medication to dogs, there's a lot of examples, of course.
Side effects, recurrence, all this is something to think about, really. And that's relatively easy to do, and the protocols are short, so it's not as expensive as a full course of treatment.
Yeah. So now that you're talking about that, because I really wanted to talk a little bit also about the other things that we use radiation therapy for. So in neurology, of course, that we use it as what we will call as neurologists palliative treatment when we cannot do a surgery in the brain or the spinal cord, as an adjuvant therapy after doing a surgery. So we are going to slow down, or maybe even completely stop the relapse of the tumor. But there is also obviously what you said for inflammatory diseases. And then there is another very important use that I think that many people, they don't think about that, which is pain control. Mm-hmm. Especially pain control in peripheral nerve sheath tumors, which we know that they are very aggressive locally. surgically, they can be very challenging, especially if you have a brachial plexus, because removing a nerve roots into the brachial plexus and getting into the dura, it can be very, very, very tricky. So that it is a beautiful use of radiation therapy. But how does radiation therapy control the pain? What is the explanation behind that?
It affects the environment of any tissue. So if it's a tumor, it would be the microenvironment of the tumor, the inflammatory component of the surrounding tissue. That's often corrupted by the tumor. So in a way, there's more and more evidence that radiation helps to switch the immune response to a better anti-cancer response locally. Mm-hmm. It releases tumor antigens. So there's lots of reason to explain how radiation can actually bring the immune response back to a good response against the tumor locally. But then if you're treating just inflammation or pain, like it works very well for arthritis, for example. If you have an old dog with very bad arthritis, that's not well even on the medical treatment, a very low dose radiation will have enough effect on the inflammatory population around mm-hmm. the joint to have a long lasting effect of 3 to 6 months sometimes with 1, 2, 3 doses of radiation only. So for this, it's great. And as a real palliative treatment for osteosarcoma, it works very well for pain control.
Yeah.
Bone mets works great. For peripheral nerve sheath tumors, I don't have much experience for the cases which are in a lot of pain or not able to use their limb anymore. The issue we have is probably that the nerve will not recover. Even if you control the disease, the nerve will not recover. And so if the deficit on the limb is very significant, probably the dog will not improve much.
Yeah.
And I'm not sure about pain control. Now, for the smaller ones, the trigeminal or sort of early stage peripheral nerve sheath tumors at the base of the spine, these were not treated forever. When I was a resident, these were not an indication for radiation. It's a sarcoma type of tumor. It doesn't work. It doesn't improve. It doesn't do anything. But it's really not true. And there's more evidence now that radiation helps, either as a stereotactic treatment or even more conventional therapy. And because they tend to be low-grade sarcomas, they're rarely very aggressive. They tend to be low-grade, slow-growing tumors. And a lot of them are early diagnosed. If you have muscle wastage on the frontal muscle, quickly the owner will notice, they will go for an MRI. So we tend to have an early diagnosis of small nerve tumors. And they can be under control. I'm not saying cured, but under control for over a year.
Yeah, you know, the problem with those, I completely agree, but I struggle to convince owners. You know what? Because as you said, the owners come saying the muscle has disappeared and they want a solution for that. And the and we can definitely control the tumor for a long time, but the muscle is not going to grow up because, as you said, the trigeminal nerve is going to be affected, which it doesn't care. We don't care about the muscle. But a lot of times, I struggle
you'd be
to convince
surprised
owners.
The muscle comes back in some ways. It's quite amazing. Okay. It's slow. It takes 6 months. It will never be exactly symmetrical. But I'm seeing cases over a year, and it does come back. And you do scans after scans. So it's still there. It's a sarcoma, so it doesn't tend to go away. It doesn't really shrink much. But it's just completely stable, and there's probably enough good nerve cells.
So that's really good to know, because that's where the people get a little bit like, oh, well, that's why I brought the dog for. And usually, as you said, the dogs, they don't show any signs of pain. They don't have any problem with the mandibula at that stage when they have the MRI. So it's a little bit difficult to sell the radiation, and then maybe when they start having the clinical signs, they're like, oh, my dog has a brain tumor. Because a lot of times that is the difficult part, is and this is why we as a vet, we need to know all this information, because we need to know what is available to offer, and what is the solution, and what is the possibility of recovery. And I think that is extremely important what you're saying about radiation therapy is not having one protocol. There's not only one protocol. There's not only one dose. There is not only one use. There is like, and this is the difference between being a radiation therapy specialist, that is your job, just to play around with that protocols, versus just look at a protocol that someone has published and then use it for every single thing, which is that
published on 5 cases. So
yeah,
it's not even science in a way. It's so the priority, because you're talking about having a client discussion that will go from the start, the first consultation, for 4 weeks of therapy. They will be worried and asking questions. And then for 6 months, they will be again asking questions, coming back for recheck. So we can't lie to them. It's very important to be very transparent about the objectives and to really define the objectives with them. There's no point to say, oh, we'll do our standard because it's the best protocol and we don't need your advice, we don't need your opinion. Because if they're not fully on board, it will flash back against you at some point. Or they will go to one vet. That happens sometimes. They go to the vet, you've got no news, and then suddenly you hear the dog has been euthanized by a local vet who never called you to ask for any information. The owners never called you because they didn't want to call you. They don't want to know. They're so not ready for everything, because maybe they went for the wrong protocol. Or at least without the good realistic objectives. Yeah. So it's not for everyone. It's very expensive. It takes a lot of commitment from the client. But they have to be patient. And for brain cases, they have to be so patient. I have cases at the moment under treatment for a tumor of the brainstem, a large meningioma of the brainstem. And the dog is now improving during therapy. Yeah, but we're still only 3 weeks in. He's ambulatory, but he's losing his balance quite a lot. And for now, there's no improvement. And it's a big Labrador, and the owners are concerned to take the dog at home because they have to carry outside and so on. So I had a long discussion today with them and say, you know, it's great, we're doing this treatment, but it's way too soon to have any opinion. I'm not pessimistic. I'm not overly optimistic. I just very realistic. I think your dog can do very well, but it might take 2 months before you see a real benefit from it. Yeah. And it's worth waiting. We see cases coming, they're barely ambulatory, they literally can't walk without any support. And when I saw one yesterday, we do a lot of brain cases. I do one yesterday, again, a brainstem case, and the dog is completely ambulatory, completely normal, and without pred, without anything now. And the owner is so happy, but it took, for that dog was on the steroids at reducing dose. But now the dog is without steroids and completely fine. So they have to be so patient.
For how long was he on steroids?
For about 4 months.
For how long was he in steroids? 4 months, okay.
4 months. Usually we keep them 6 after radiation. We reduce the dose slowly. It's really much for the patient to tell us how much steroids he needs after radiation. So every 2 weeks, slowly we reduce the dose. And if it's worse, we go back to the previous dose. If it's stable, we wait another 2 weeks before we do another step down. But some dogs will need a bit more steroids, a bit longer. Usually not very high dose, but maybe just half milligram per kilogram every 2 days sometimes. But yeah, this dog was just and the owner's so happy, and the dog's completely fine and ambulatory now. So you can never predict everything. The problem is you cannot give guarantee either. So some dogs do bad, and some dogs die during treatment. Some dogs will die within that 2 months period after radiation because of some acute swelling, brain stem, cerebral herniation probably can be a risk.
Yeah.
But it's so rare. It's so infrequent. I think the last dog I died quickly was a bit of a shock because it was a good case, not palliative, but really a good case. Maybe it's a dog died 5 years ago. So most cases we treat tend to do very well. It's a very good for us. It's a very nice indication to treat because we don't have the skin side effects. We don't have all the side effects in the mouth, and it's just the brain. So in a way, it's quite easy to monitor and to treat. Yeah.
So there are two questions. One again from Patty, and then the other one which you have actually answered a little bit, but we just remind quick. So Patty was asking how quick will you re-irradiate after you have done a protocol for a brain tumor?
So the good answer is probably we should not re-irradiate much because the brain tissue is very tolerant to radiation, to a first course of radiation. But the dose we give, the damage we do to the brain cells, is probably permanent for a lot of them. There's no going back, unlike other tissues where there's some level of recovery. For brain tissue, the recovery long-term is probably very, very small. Now, if you've got a case who did very well after the first course of treatment, let's say a meningioma that finally grows back after maybe 2 years or 3 years.
I think that, Jerome, will be also important to think about what part of the brain we are doing, because we know that certain parts of the brain, they are a little bit less important or less epileptogenic than others.
Exactly, for sure. So it's what location in the brain, how big is the volume, is there any, we need to be sure that the tumor is actually coming back. And it's not always easy in neuro cases. Sometimes you have what's called pseudo-progression of disease, which can be just a necrotic tumor that looks like a mass and there's edema, but it's not growing. It's just, actually it's dying. And even in some cases, it's quite challenging to know if it's actually tumor recurrence, pseudo-progression, or brain damage, just brain necrosis. Now, if we have to retreat, so there are cases we did well the first time, had a long remission, so over a year, ideally 2 years for brain probably. And the protocol will be different. It will be a bit shorter, less dose. We cannot give another time a full dose of radiation to the same place. The beams will have to come from different angles. So we try not to match the first plan, but we go from path of beams that were not as exposed the first time to try to minimize side effects. It's always a risk. It's really has to be taken in agreement with the client. It's more palliative, it's more short-term, and there's even more risk for true brain damage. But if you have no other options, why not?
Yeah, exactly. The ultimate brain damage is that the tumor is gonna kill the brain. Okay, so Jerome, before we finish, I just want to thank you very much for all the information, and then just want to let you know, guys, that Jerome does some. He's actually also a consultant he does it all over the world for people that they want to set up, whether buy a linear accelerator, set up a radiation and oncology service, and he will help any of you to do that and to create your own team. Again, buy your super expensive linear accelerator. Cannot even imagine how expensive is that to buy, but obviously you need to know what you want to buy.